Good morning, everybody. Today, my paper presentation is on correlation of LV mass index and vitamin D levels in essential hypertension. Introduction. Essential hypertension is a major risk factor for cardiovascular disease, often leading to left ventricular hypertrophy, which is best assessed by left ventricular mass index, which is the quantitative value to measure the left ventricular hypertrophy. Vitamin D deficiency increasingly recognized in hypertensive patient, which may influence cardiac remodeling through effects on renin-angiotensin system and myocardial function. Studying the correlation between vitamin D levels and LV mass index can provide valuable insights into the cardiovascular risk and management. Aim and objective: to evaluate vitamin D status and correlates its association with echocardiographic indicators of LVH in patients with essential hypertension. This study is a prospective study which was conducted on 100 patients of essential hypertension after obtaining approval from Institutional Ethics Committee. Inclusion criteria were non-cases of hypertension aged above 18 years, while pregnant females and patients with causes of left ventricular hypertrophy other than essential hypertension were excluded, like causes of secondary hypertension, renal endocrine causes, and also the left ventricle valvular heart disease related to left ventricular hypertrophy. These were all excluded from the study. All participants underwent baseline investigation including serum vitamin D levels, thyroid function test, random blood sugar levels, and 2D echocardiography for assessment of left ventricular mass index. Echocardiographic measurements. LV linear dimensions including interventricular septal thickness IVSD, posterior wall thickness PWD, and left ventricular and diastolic diameters were measured. To calculate LV mass using the formula, LV mass is equal to 0.8 into bracket 1.04 into LVEDD plus PWD plus interventricular septal diameter cube minus LVEDD cube plus 0.6 gram. The LV mass index can be was derived by dividing LV mass by body surface area. So normal reference were defined as 95 gram per meter square in females and less than or equal to 115 gram per meter square in males, and left ventricular hypertrophy was diagnosed when LVMI exceeded these thresholds. Mean age was 59.7 plus minus 12.7 years, majority 60% were 51 to 70 years, with slight female predominance 55%. Overweight obesity was seen in 66% and only 2% were treatment compliant out of total people who are getting treatment. Vitamin D deficiency was common, 62% deficient, 20% insufficient and 18% sufficient. These results were consistent with our national average of 75% of people with low vitamin D levels. In my study, deficient plus insufficient is 82%. So these values is consistent with the national average. Echocardiography showed in high prevalence of abnormalities, abnormal LVMI in 66% patients, interventricular septal thickness in 90%, posterior wall diameter in 92%, and left ventricular and diastolic diameter in 53% is abnormal. Significant association found between vitamin D levels and posterior wall thickness. P-value is 0.031, which is less than 0.05. Trend shows higher LV mass index and wall thickening in vitamin D deficient patient. The mean values of posterior wall diameter amongst vitamin D groups were 1.38 centimeter deficient group, 1.32 centimeter vitamin D insufficient group, and 1.31 in sufficient individuals. While the difference were not statistically significant, categorical analysis showed only 3.2% of deficient patient had normal PWD versus 22.2% in the sufficient group. So the mean values of posterior wall diameter among the different group in lower vitamin D levels and normal vitamin D levels is not much difference is there, but the number of patients which I get in the deficient group is way more than the sufficient group. Like only 3.2% patient of deficient vitamin D group has normal posterior wall diameter, but 22.2% in the sufficient had normal. So the difference between the number of patient is bigger, but the absolute mean values of PWD has not much had difference in between. Like they are abnormal, but not much difference. Additionally, patient with abnormal posterior wall diameter had a mean vitamin D level of 21.12 plus minus 19.4 nanogram per milliliter compared to 32.63 plus minus 15.9 nanogram per ml in those with normal thickness. The deficient vitamin D individuals were 62% and insufficient were 20% and sufficient is 18%. So this consistent with the national average data, and these in this second graph, this is prevalence of echocardiographic abnormalities in all the patients. In deficient, sufficient, insufficient patient, these are the echocardiographic abnormalities in all the parameters: LVMI, interventricular septal thickness, posterior wall diameter, and end diastolic diameter. So we found only the significant relationship of LV mass index with only posterior wall diameter. But as you can see, the trend shows this is the first is normal LVMI, abnormal, then in all the parameters. The trend shows the blue mark with the in the deficient individuals, vitamin D. So the trend shows the higher values of abnormalities in a vitamin D deficient individual across all the parameters. Across all the parameters, we can see the highest abnormalities seen in the vitamin D deficient individual, followed by insufficient, followed by sufficient individuals with vitamin D levels. Conclusion: vitamin D deficiency was highly prevalent, 62% in hypertensive patient who also showed obesity, diabetes, and proteinuria. A significant association was observed between vitamin D status and posterior wall thickness, indicating a protective role of sufficient vitamin D against myocardial thickening. Although other parameters showed non-significant trends, these findings suggest that routine screening and correction of vitamin D deficiency may aid in cardiovascular risk management. Thank you.